Hi everyone, it's Karen here, and welcome to episode 1 of series 4. I don't know how we've cracked out 3 series already of Probably Nothing, but we have, and here we are. Welcome to episode 1, series 4 of Probably Nothing, the weekly live chat show, online program, whatever you want to call it, from us at the Eve Appeal. So, as I said, my name is Karen, but I'm a nice Karen, I promise. And I run the Ask Eve information service with our gynae nurse, Tracy. And we started Probably Nothing back in June last year because we were getting lots and lots of emails and calls from wonderful people who were saying, oh, hello, sorry to bother you. It's probably nothing but. And then they would go on to ask their gynae cancer question. And the kind of positive thing, I suppose, is that most of the time gynae health concerns won't result in a gynae cancer diagnosis, but sometimes for some people it is something more serious. 58 women every day in the UK are diagnosed with a gynae cancer, so we wanted to create an online kind of informative accessible way to talk about different gynae health issues. So March is Ovarian Cancer Awareness Month, so series 4 is going to be dedicated to different aspects of ovarian cancer. And our first guest today is Adeola Olaitan, Consultant Gynecological Oncologist. Oh my God, I got that right. Yes, high five myself. She's also an ambassador for the Eve Appeal, someone I adore and I pester frequently with emails, some work related and some not. And she always replies very quickly, sometimes in the middle of the night because she is such a busy superstar that she barely sleeps. But anyway, with Adeola today, I'm going to be talking to you about ovarian cancer symptoms. We're going to start off the series by telling you what to look out for when it comes to ovarian cancer. So please welcome Adeola.
Hello, Karen. Thank you.
Hello. We've swapped over, haven't we? Because often I wear black and you're in a lilac or a scarlet, and we've swapped over today.
Indeed, and I love your lilac. It's very pretty.
Oh, thanks, babe. Adeola, so ovarian cancer. So if people don't know, it's the second most common of the gynae cancers after womb, and it's the 6th most common cancer in women overall. Now, often with gynae cancers, we are quite positive when we talk about symptoms because, if someone has a bit of a postmenopausal unusual bleed, they can go to the doctors, and if they've got a womb cancer, it's often in that case diagnosed quite early in the sort of typical womb cancer picture. But with ovarian cancer, well over 50% of cases are diagnosed at a later stage, so a stage 3 or 4. So it's a little bit more of a serious chat, I guess, just because, the outcome is often not as positive as we would hope for people. Can you start by just kind of telling us a bit about the disease and why it is diagnosed so late compared to, for example, a sort of typical womb cancer?
Well, absolutely. So ovarian cancer, although you say, as you correctly say, is one of the second commonest gynecological cancer, is actually, in the grand scheme of things, not a very common cancer. And therefore, GPs are probably not used to seeing women with ovarian cancer. If we start right at the beginning, the symptoms, they're often vague and nebulous, and they often mimic symptoms of benign disease. So the ovaries are 2 small organs that are located deep within the pelvis, and they don't usually hurt. So as the ovaries get bigger because of a tumor, they start to impinge on other organs, and the symptoms can usually relate to other organs, such as the bladder or the bowel. So the first symptoms may be a little bit of abdominal discomfort, a little bit of what women describe as bloating, where your clothes don't feel right and your tummy just doesn't feel right. And it can mimic symptoms of irritable bowel syndrome, which is terribly, terribly common. And very often, busy women, we self-diagnose and we say, well, it's probably, IBS, I'll take something. And then a few weeks go by and things are not better. And then you might see the GP. And as I said, it's not a terribly common cancer. And a GP probably sees one woman with ovarian cancer every 5 years. So again, they think about the common things like irritable bowel syndrome or constipation. And so it can take a long time before people consider that this might be ovarian cancer. And by then, very often the cancer has spread beyond the ovaries and still treatable, but harder to treat.
So you say bloating is kind of often the first thing that someone might notice, whether they know it's ovary related or not, but that's kind of sometimes the first sort of warning sign. We often talk about, when we kind of do our awareness sort of things, we talk about persistent bloating. Can you kind of just explain to us from your perspective what that would mean when you see a patient, a persistent bloat compared to, me just saying, oh, I feel bloated today? I wouldn't be worried because it's not persistent.
So it's basically it's a symptom that doesn't respond to your usual measures. So I mean, most women, especially, I mean, fair to say, ovarian cancer is usually diagnosed in postmenopausal women, but it can occur in women who are cyclical. And you're used to probably premenstrually having a little bit of abdominal discomfort. If that persists and is no longer cyclical, if it goes on beyond 3 weeks, then you should seek help. And I think one of the things, you mustn't be afraid when you seek help to say to the GP, might this be a symptom of ovarian cancer?
I'm so glad you said that, because I was about to tell you, I was like, I run the Ask Eve service. You know that. That's why we're here. um, but I do sometimes feel a bit nervous when I say to people who kind of list some potential ovarian symptoms, and I do that. I do what you say. I say to them, please don't be afraid to say the words ovarian cancer. And I sometimes feel nervous saying that because I don't want people to panic unnecessarily, because they might just kind of contact us and say, oh, I feel a bit bloated and need a wee a lot, and then I've suddenly said, please ask to rule out ovarian cancer. But isn't that a good way of getting it on the GP's radar?
Absolutely. Because as I said, if you only see one woman with ovarian cancer every 5 years, you may not think about it. And it would lead to the appropriate investigations. And I mean, the best outcome is it isn't, but you want to know that. And I don't think there's any room for guessing. I think you want to know for certain if you have got a cancer, so that appropriate measures can be taken to treat. So I think that's probably the right advice.
Thank you. And you said about bloating. So say someone has got the persistent bloating. So again, more likely to be something other than ovarian cancer, but there's somebody who has persistent bloating for 3 weeks or more. Is that kind of enough for you as a gynae onc to ring alarm bells for ovarian cancer, or do you expect to see other symptoms along with this sort of puffy, persistent bloating?
I think it's enough to think about it. Often people may not have other symptoms. Obviously, the more other symptoms they have, like early satiety, so you can't eat very much before you feel full, having to pass water very frequently, they're all pressure effects, or a tummy that's distended. All of those additional symptoms add additional worry. But I think if somebody's got persistent bloating and they're of an age or when you would consider ovarian cancer as a possible diagnosis, it does no harm to get a scan.
And you mentioned IBS before, so often it's kind of confused with or initially presumed to be IBS because IBS is a million times more common than ovarian cancer. So if you had to pick if someone's got IBS or ovarian cancer, it's probably the tummy toilet stuff rather than the ovaries. But is it true that the older you get, the less likely it is to be IBS? So it's more that you wouldn't expect a 55-year-old woman to have sailed through life and then at 55 suddenly have IBS.
Oh, completely. I mean, it's so unusual for it to be a symptom in a middle-aged woman. And also, I think that IBS, which stands for Irritable Bowel Syndrome, is a diagnosis of exclusion. So there is no test you can do to prove, or no easy test to prove that somebody's got IBS, but there are tests you can do to prove that they haven't got something else, like a bowel problem or ovarian cancer, that are causing symptoms that mimic IBS.
Interesting. Okay, so whilst it's less likely that someone who's older will have IBS, it's not like you can just have a pinprick blood test for IBS. So it's kind of investigating the whole picture. And what would you say to someone, so say they have got some potential symptoms for bowel problems, and have been referred down that pathway, and nothing is coming up, and the bowel lot at the hospital are like, no, you're absolutely fine, but you're still bloated, you're still going for a wee loads, and constipation and or diarrhea can be a sign as well for ovarian problems, can't it? So we've got persistent bloating, kind of abdominal pelvic pain, urinating more frequently, feeling full more quickly than normal, feeling quite sick when you eat, constipation and bowel problems. And say the initial sort of tummy toilet route at the hospital comes up with nothing, but all the symptoms are still persisting. Can the bowel team at the hospital just go, hello, Adeola, this is Karen. She's got nothing wrong from us. Or do I have to go back to the GP?
So very often, and that's very often how my patients with ovarian cancer come to me, they come by the bowel route. And very often, investigations, they might get a scan, and the scan will show there's some swelling in the pelvic region, which is clearly not gastrointestinal. And very often they'll say, look, can you have a look at her, because we think it's more likely to be gynecological. And yeah, I mean, most patients come to us via the gastroenterologist or via A&E or some other, or even the urologist. They very seldom come to my 2-week wait suspected cancer clinic directly to me.
I understand. And so say someone has got all of the symptoms we listed, which, for everyone watching, we will put out throughout the month in very kind of clear social media format, so you can see the list clearly, and it's obviously on our website in the ovarian cancer section. So say someone's got all of the potential symptoms we mentioned, they go to their doctor and they use the language we just suggested. Hello, I've got all these problems, I want to rule out ovarian cancer. What's the sort of first thing that happens at the GP surgery?
So it is quite likely, well, I would expect that the woman should be examined to see if there are any lumps and bumps. And in addition, very often, the first test they may have is a blood test called a CA125. CA125 is a protein in the blood that's secreted by ovarian cancer cells. It is not diagnostic. And you can have a raised CA125 for lots of other reasons, like endometriosis, appendicitis, bowel trouble. So a CA125 on its own does not make a diagnosis of ovarian cancer. And the other thing to bear in mind is that 50% of women with early ovarian cancer will have a normal CA125. So very often that is accompanied by an ultrasound scan, which might be an abdominal ultrasound scan or a transvaginal ultrasound scan. And the combination of a pelvic mass and a raised CA125 ought to raise the possibility that this is an ovarian cancer, and the woman should be referred rapidly for further investigations and confirmatory tests.
And is the CA125 blood test, is that something that can be done at the GP, or do they have to go and see a specialist to have these CA125 levels tested?
No, it can be done at the GP. And my understanding, if the guidance hasn't changed, is that GPs are encouraged to do it if they suspect that somebody's got ovarian cancer.
So CA125 test, to kind of summarise that bit, it will not tell you you've got ovarian cancer, but it's a helpful indicator in some cases when piecing the ovarian picture together or starting us off on this sort of investigation.
Correct.
And say someone's got raised CA125, and then will their GP be the person to then send them for a scan? Is that kind of how it works?
It varies. Some GPs might think if it's very raised, if it comes back with big numbers, they may think, well, let's not waste time getting a scan done. Let's just get you to hospital, and they refer you immediately. If it's borderline, they might think, well, let's get a scan done first and then refer you. So either is a possibility.
And so ovarian cysts are fairly common, aren't they, in kind of the grand gynae scheme of things. Could something like an ovarian cyst that is not going to kill you, it's not cancer, could that cause all of these problems as well, for example, or not?
Indeed, it can, because as I said, they're all pressure symptoms. So if you have a big ovarian cyst, you can have all of these symptoms. And that's where a scan is very useful, because scans help us to decide whether a cyst is likely. So a scan, again, cannot make a diagnosis, but it helps us decide whether a cyst is likely to be benign or malignant. So what do we mean when we say cyst? It's just a fluid-filled area of the ovary. And if it's completely simple, just a bag of water, then in the vast majority of cases, this is benign. The more complex the architecture of the cyst, the more suspicious we are. So if the cyst has divisions within it, what we call septi, then that kind of makes you think, well, this isn't quite simple. If it has solid areas and cystic areas, then again, that raises the possibility. And if the ovary has growth on the surface of the ovary, then we have to say that this is ovarian cancer until proven otherwise. But a scan is not going to tell you what it is. The only way of making the diagnosis is getting some tissue and looking at it under a microscope.
So if you saw a mass that you think this is probably a cyst, would you so is it true, this, you correct me if I'm wrong, that kind of simple cysts, I was about to call them boring cysts, but well,
Well,
they
not
are
boring if you have them.
no, I can imagine. But simple cysts, do they often go away within a few menstrual cycles, or is that not true? Is that a rumor I've heard?
So no, they often will. And if they're simple and they're small and they're not particularly symptomatic, you'll very often be told to come back and be scanned in about 6 weeks' time, and they will go away. If they persist, then you might want to consider doing something about it. So they are at the very non-worrying side of the spectrum.
And so say you've seen a mass that you're not sure about, would you if there's ever any uncertainty, would you kind of ever send someone away and say, come back in a bit and we'll recheck? Or if you have any suspicion, would you always take a sample?
So if the cyst is suspicious, if it has all of these features that makes it what we call a complex cyst, then we would not say come back in a while. We need to make a diagnosis because we want to exclude a cancer. And if you leave it a few weeks, that could get worse. Now, if the abnormality is confined to the ovary, then we don't like to biopsy the ovary because that has the risk of spilling abnormal cells. So the safest thing to do if an ovary fulfills all the criteria for raising high suspicion of abnormality is taking the ovary out in its entirety to make a diagnosis.
That's quite different, isn't it, to the other gynae cancers, in that you would have, at cervical, you would have a little bit taken out and looked, but with the ovary, it's kind of dodgier to take a bit out. If you've got enough of a reason, it's better to take the whole thing out.
Absolutely. The other thing, all the other gynecological cancers kind of have an external outlet for you to biopsy. So if you're talking about the vulva, the cervix, or indeed the endometrium, the lining of the womb, you can take a biopsy from the vagina. The ovary is inside your pelvis, and so you have to go through the skin to take a biopsy, and then you have the risk of seeding malignant cells. So we don't recommend that as a rule.
So that's done kind of through the tummy rather than up through the vagina.
It can be done through the vagina as well, but you're crossing tissue barriers, as opposed to if you're taking a biopsy from the lining of the womb, for example, you're going through the cervix, through a natural orifice. So, I mean, we do sometimes take biopsies for ovarian cancer, but that's if the cancer has clearly spread beyond the ovary and you want a tissue diagnosis to confirm and perhaps help to plan the treatment. But if it's just one abnormal ovary, then the correct treatment is to take out the ovary.
To take it out. Okay. That's so interesting. And it really just shows, doesn't it, kind of the distinguishing kind of approaches to ovarian compared to, I know obviously like womb, vaginal, cervical, vulval are all different to each other, but it feels like there's sort of the four of them and then they're different within their own category. And then ovarian is kind of a whole other ball game.
It is actually, and the treatment. And I mean, I correct myself because I said taking out the ovary is the correct treatment. That's not entirely true. That is the correct way of making a diagnosis. Taking out the ovary and it may not be the entire treatment,
but it could be if it was early. Potentially.
Be, but the way that you prove it's early without getting too technical is also to exclude microscopic spread elsewhere. So if it's a proven cancer, then it is quite likely that we would have to take samples from other parts of the body to make sure it hasn't spread anywhere else.
And just because this is probably just because I like the sort of percentage and numbers and things, in your experience of ovarian cancer, I said at the beginning of the show that, you know, well over 50% are diagnosed kind of in the 3 or 4 stages. Does that sort of ring true with you and your practice? You do see well over half of the people at a later stage, or do you tend to find
the vast majority are diagnosed with late stage. A lot of people who are diagnosed with early stage ovarian cancer, it's usually an incidental diagnosis. So they're having a scan for something else and they actually have no symptoms suggestive of ovarian cancer. And then an abnormal ovary is picked up and they come my way. And it's really important to say, because ovarian cancer has a really bad reputation and people think it's very difficult to treat, but early ovarian cancer, confined to one ovary, the cure rates are in excess of 95%. So it is a treatable cancer. The challenge we have is that people often present late where treatment is more difficult and cure is more difficult.
Because often in this kind of conversation around, you know, someone will share their story or of a lost loved one, and often with ovarian cancer, there's a lot of emphasis on real and understandable kind of sadness and anger and frustration that it was diagnosed late, which is completely understandable. But it's and kind of like what we said earlier, that, you know, a GP won't often see an ovarian cancer, so it's understandable, and because it's not that common compared to everything else, it's kind of understandable they go down a different pathway initially, but we can't blame that solely on a late diagnosis, can we? Because the reason they're feeling poorly in the first place is probably, if it is ovarian cancer, which again it's unlikely to be in the grand scheme of things, but it's probably because it's gotten to a later stage in the first place for them to feel anything at all, even before they've been misdiagnosed.
Yeah, no, absolutely. Because as I said, the ovaries start to give you symptoms when there's pressure on other organs. So generally speaking, the ovaries are quite enlarged or other organs are involved before you become aware that, you know, something's not quite right.
We've got about 7 minutes left, so I've just got some questions that have come in. Can I just fire them at you, please?
Of course you can.
Oh, I can say anything to her, isn't she wonderful? Okay, they are about ovarian cancer. It's not just like, where did you get your dress from? Okay, so we've covered already sort of, is CA125 the first test a GP will do?
Very often is, yes.
I'm worried about my gynae health. I have a family history of cervical issues, and I've seen your Instagram posts about ovarian cancer, and I have a lot of similar symptoms. What should I do?
Go and see your GP, explain your symptoms clearly, have an idea of how long you've had these symptoms for. And as we said, do say, could these symptoms be suggestive of ovarian cancer?
And just to kind of, well, again, correct me if I'm wrong, but there's no link between cervical and ovarian, is there?
No link, no.
So go to your GP, but also the family history of cervical issues, when it comes to your potential ovarian cancer symptoms, sort of they're separate. So not that obviously cervical issues aren't important, but they're not relevant to your potential ovarian symptoms. Is bloating the most common symptom you see of ovarian cancer, or is it that bloating is just a common thing?
It's yes to both, actually.
Yeah.
Yes, bloating is a common thing. As we alluded to earlier, cyclical bloating in the second half of the cycle, a lot of women will experience. But bloating is often what women will describe when they have symptoms of ovarian cancer, that kind of vague fullness, fat tummy, not quite feeling right. Yes.
So yes to both. Okay. So we've covered how is it actually found and diagnosed if you have symptoms. A scan will maybe suggest a mass, and then you would go and investigate and take the ovary out if you see, etc., as we were saying earlier. Where are we? I'm very bloated. Here we go again. It's bloating, isn't it? I'm very bloated and need a wee all the time, but my smear, so cervical screening, my smear in January was clear. Should I be worried?
Really important to understand that a cervical smear just looks for abnormal cells on the cervix. It makes no other diagnostic attempt at any of the other gynecological organs. So yes is the answer. If you've got symptoms, regardless of your smear result, go and see your GP, describe your symptoms, get investigated.
Yeah. So cervical screening is in no way linked to ovaries whatsoever, completely separate. So it's, we talk all the time about gynae health, gynae cancers, but if you can in your head, when you think about your gynae health, try and think of them as sort of separate entities. So your cervical screening, it's great, it was clear, but that's got nothing to do with potential ovarian problems. Two more. Okay. So I had an ultrasound scan to check for cysts. I still have symptoms. Could the scan have missed an ovarian cancer?
So it would be very unlikely if the scan has seen both ovaries and the ovaries are normal. And if you still have symptoms, then one has to consider what else is in your tummy. It could be symptoms of bowel problem or symptoms of a urinary problem. So if a gynecological problem has been excluded, it's important that the other two systems are investigated.
But from an ovarian cancer perspective, it's very unlikely a scan would have just completely missed a disease.
It would be highly unlikely. If they've said that they've seen both ovaries and they're normal, then we have to accept that that is the case.
Okay. And last question is, how many times should you go to the doctors and they tell you you have IBS before asking for a second opinion?
That's a good question because, as we said, IBS symptoms are really common, but if they don't respond to the therapy that the GP offers and the symptoms persist, I think that if you've been once and things haven't got better and you're being offered more of the same, you should ask for a second opinion.
And what would you kind of, just as we end, say to people to kind of not restore their faith, but to encourage them to persist? And I think often people, again, kind of like what I said right at the beginning of this, people say, oh, it's probably nothing, sorry to bother you. We often get people say they don't want to bother their, I don't want to bother my GP, I don't want to pester. But if something hasn't been investigated thoroughly, or if there's no answer, what would you kind of say to people to sort of, I guess, make them feel a bit better about potentially pestering the doctor?
I think it's your health, and I think it's really important if you think that you have symptoms that are suggestive of a cancer, that the symptoms are thoroughly investigated and if cancer either excluded or confirmed. So I think that that's what we're here for as doctors, both general practitioners and specialists. And I think if you're not satisfied, you must go back and say, would you be happy to refer me for an investigation? I think it's entirely the right thing to do.
Thank you very, very much, Adeola. I'll say goodbye to you like backstage in a second. We've got a secret area. But I will, to the public, say thank you so much for answering those questions. You explained everything, as always, really clearly. And I think anyone watching this will have a much better understanding of the potential symptoms. Thank you.
Thank you so much, Karen.
See you in a minute. Thank you. Oh, I adore her so much. Honestly, doing probably nothing is absolutely one of my favourite parts of the job at Eve Appeal. Thank you so much to everybody that's tuned in for this first episode of Series 4 of Probably Nothing. And we've talked about the symptoms of ovarian cancer and what to do if you're concerned. So next week, we'll be back with another ovarian cancer topic, kind of kicking off with the question, I've just been diagnosed with ovarian cancer. What happens next? So we'll be talking through the treatment options, kind of potential hereditary risks, that sort of thing. If you've got any questions that you want us to answer in the session next week, please do email them to probablynothing@eveappeal.org.uk. But if you want to use the Ask Eve service at any time, not just on that session, then please do email nurse@eveappeal.org.uk, and Tracy or I will get back to you as soon as possible. So thanks so much for watching. See you next week and stay safe.